So what are the main functions of the platelet? The platelet, other than playing important role in the hemostasis and thrombosis, it has various other roles like maintain the and regulate the vascular tone, and also plays an important role in the tumor biology and also in inflammation and host defense. That's why we most commonly see patients with thrombocytopenia not only having a bleeding symptoms, sometimes they will come only with the severe body pain, unexplainable body pain. That is also a common manifestation of thrombocytopenia because of these various functions other than only the bleeding and clotting disorders management. So what is low platelet count? We know the normal platelet count is between 1.5 to 4.5 lakhs. When it comes below 1.5 lakhs, we usually say thrombocytopenia. And if it is, we usually divide this thrombocytopenia into mild, moderate and severe depending upon the counts of the platelet. If it is between 1 to 1.5, then it is mild. 50 to 1 lakh, it is moderate. And if it is less than 50, we call it as severe thrombocytopenia. So what is the commonest presentation of thrombocytopenia? As I already told, most of the time the presentation will be the bleeding manifestations. Like they will have a bleeding from any part of the body, most commonly in the skin, petechiae and bruises. Other than that, there can be a severe menorrhagia, epistaxis, GI bleed, hematuria. So anything can be a manifestation. So normally we get the severe bleeding like intracranial bleed usually ranges from, it is very common in the adult population compared to the pediatric population, whatever the platelet count. Usually in the adult it can go up to 20%. For the pediatric population it will be usually less than 5%. So when, because most of the time when we get the platelet around 10 to 20,000, so what are the other indicators to say that this patient may have a severe bleeding is that other than the platelet count, the patient may have a multiple hematomas or the wet purpura, which is a very important indicator to say that this patient may have a impending intracranial bleed. So wet purpura has to be carefully looked after, and also we have to see this other fever. Even if the patient having the platelet around 50,000 and if the patient is having a fever or sepsis, then the risk of bleeding is very high. So what is the causes of thrombocytopenia? It can be due to decreased production or increased destruction, or it is getting sequestrated in the spleen. So the production defect could be due to any infection or leukemia or anything is infiltrating the marrow. Or it can be due to chemotherapy or radiotherapy or drugs. The drugs are very common cause of thrombocytopenia. So whenever we get a patient with thrombocytopenia, we have to ask the clinical history. What is the recent drug they have taken? So that is very important. Other than that, any nutritional deficiencies can cause, and hereditary also we can have a mild thrombocytopenia. Increased destruction, the most common cause could be the ITP. Other than that, we can get thrombotic microangiopathy, anything can cause increased destruction in the platelet, or it is getting sequestrated, normally getting produced and normally getting destroyed, but it is getting sequestrated in the spleen. It could be due to hypersplenism, that is portal hypertension, and NCPF, anything can cause this sequestration in the spleen. So with this basic knowledge, we will move on to few interesting clinical cases. This is a 47-year-old lady. She actually underwent a dental scaling. There was no bleeding. She was clinically doing fine and healthy. During routine investigation, she found to have a platelet of 16,000. She is clinically fine and healthy, no bleeding manifestation. She recently underwent a dental scaling also. That was also uneventful. And all the clinical parameters, including the CBC, no organomegaly, lymphadenopathy, everything was perfect. So what do you suspect in this patient? So the platelet is only 16,000. Do we need to give admission immediately, or do we need to give transfusion immediately? What is the next test of choice would you like to proceed? Yeah. So whenever we get a CBC, most of the time we get a printed report that the laboratory technician will copy the report from the print machine which is giving. So they will miss some flags which is commonly shown in the CBC parameter, that is in the CBC, this parameter we can see there can be a flag like PU, PL, so those things I am not going to go in detail. Just you can see this histogram. In the platelet histogram you can see this flag. Point. Can I get a pointer? Can I get a pointer? So So this platelet histogram, you can see that normally the size of the platelet, it will be between the 10 to 20 microns. So here you can see there is some zigzag puzzle-like pattern. So this is not normal platelet histogram. So you can see the histogram, it should go up and come down, but here there is some zigzag pattern. So this is not a normal histogram. By seeing this itself, you can say that there is some error in the machine or something is wrong, not with the patient, with the lab. So immediately we can order for a peripheral smear examination. So for this patient, there are so many platelet clumps are there. So this clump is actually causing the thrombocytopenia. It is not the disease which is, why these clumps are happening. This could be due to improper mixing, or it can be due to the EDTA, which is actually have natural antibodies are present in the human body, can react with this EDTA. That can also cause this sort of aggregation. So whenever you get a suspicion with the CBC histogram, you can order for a peripheral smear and you can get a clear idea that what actually we are dealing with. So whenever we suspect it could be a pseudothrombocytopenia, the repeated blood examination has to be done not with EDTA, it can be done with the sodium heparin or sodium citrate, that is in the blue vial or green vial, instead of using the EDTA, that is a purple vial. So always we know that we need to treat the patient, not the test results. Coming to the case number 2, this is a 24-year female patient presented with a bleeding gum, 2 weeks duration and fever spike. Actually, the patient is complaining of mild increase in the body temperature, also complaining of menorrhagia. She is having heavy profuse bleeding for the past 5 days, and it was actually a regular cycle, but having a profuse bleeding associated with the passing clots. So 24-year female presented with the bleeding manifestation. Clinical examination, no organomegaly, only anemia. The hemoglobin was 4 grams with a platelet count of 10,000 with a total count of normal total count around 4,000. So as we know, the next further investigation should be the, so with this clinical picture, anyone can suggest what could be the DD for this patient? Severe anemia. So most of the time we may get panic that this patient might be having some hematological malignancy. Severe anemia is there. So we can correlate with the clinical history. This patient is actually having a severe menorrhagia. So that menorrhagia causes this sort of severe anemia. So anemia, other than apart from anemia, nothing is abnormal other than severe thrombocytopenia. Why I am highlighting this? Because the possibility could be in this case ITP, right? So acute leukemia is the one DD and another one is the ITP. So how to diagnose ITP? ITP, we know it is a diagnosis of exclusion. So, and we also have to ask for the infective and drug causes has to be definitely ruled out. So ITP has to be definitely differentiated from the acute leukemia. Why? Because ITP, the treatment of choice is steroid. In case of acute leukemia, if we start steroid, the blast will get disappear. So before coming to a proper conclusion, we should not start steroid. So the differentiating features between ITP and acute leukemia, usually in patients with acute leukemia, we may get a lymphadenopathy, organomegaly, or the patient can have a bone pain, sternal tenderness usually will be present, gum hypertrophy will be present, and the anemia usually disproportionate to the bleeding history will be very severe, and the total count variation. Total count may be high, too high, or too low. So these are the points to say that this patient could have a acute leukemia. So what next? As usual, peripheral smear examination is very, very mandatory, and it has to be examined by the experienced pathologist, because if the blast, most of the time the pediatric blast will get missed in the peripheral smear examination if we don't see it properly. So the peripheral smear examination is mandatory to confirm that it could be an ITP or acute leukemia. So is it mandatory to do a bone marrow aspiration for a diagnosis of ITP? It is no. No need to do a bone marrow aspiration for the confirmation of ITP. What are the indications to do a bone marrow aspiration? If the patient is having any abnormal features like the counts are too high or counts are too low, or if the patient is having a B symptoms like a fever, and if the patient is having any lymphadenopathy, organomegaly, or if the patient is more than 60 years, or if you are planning for a splenectomy, just to get a definitive confirmation, you can do a bone marrow. So otherwise, bone marrow examination is not mandatory to do to diagnose a ITP. So can we start steroid immediately? No, definitely we should make sure that we are not dealing with. If you have any doubt, if the peripheral smear, if the pathologist have mentioned some atypical lymphocyte, just do a marrow, just rule out acute leukemia, then you can consider to start the steroid, because as I already told, blast will get vanished with the 1 dose or 2 to 3 doses of steroid, and the peripheral smear, if pathologists are not experienced, may miss the blast. So we know how to treat. I'm not going to go in detail. So when to give a platelet or PRBC transfusion? This is because very important question, because most of the time we give transfusion even if the patient is having some bleeding manifestations. So what are the indications to give? So the definitive indication is that if the patient is having any CNS or life-threatening bleed, you can consider giving steroid. Otherwise, as we know, the ITP itself have antibody that will cross-react with whatever the platelet we infuse. So definitely, platelet infusion is not the first treatment for the patients with ITP. So you have to consider treating with platelet whenever the patient is having a CNS or life-threatening bleed, you can consider. So what are the platelet products available? We know there are 2 platelet products. One is which is available in India. One is random, another one is the single donor platelet. The single donor platelet, which is actually collected from the apheresis machine, and it actually increases the platelet count up to 30,000. One single donor platelet is enough to rise up to 30 to 40,000 of the platelet. Normal, the storage will be around 20 to 24 degree, and it is usually stored for 5 days. So the very important point we have to consider while giving the platelet is that it should be infused very short duration. It should not be need not to be given for 15, 20, 30 minutes. How much time short it is possible we can give, because the platelet will get activated in the bag itself and it will release all the constituents. So you will miss the effective functional platelet. So the platelet transfusion has to be given within 10 minutes, very fast as possible. So the I have so many slides to go on. This is the third case. This patient, actually 47-year female patient, presented with a generalized tiredness and weakness, and she actually had an altered sensorium. Referred for thrombocytopenia and anemia. The patient was actually admitted in ICU, and it was a call from ICU for anemia with thrombocytopenia. And this patient actually having a bilirubin of 1.9 and creatinine of 2.3, and this peripheral smear gives a diagnosis. What could be this? So it is having a fragmented RBCs on the peripheral smear. So the possibility of microangiopathic hemolytic anemia has to be considered in this case. So this is a pen test to diagnose TTP, that is fever, seizure or altered sensorium, anemia with cystocytes in the peripheral smear, thrombocytopenia with raised creatinine, and I think I'll finish over, sir. There are so many more slides to go. Thank you for the patient listening. Thanks a lot.
Thank you very much, madam, for a wonderful presentation. It's a very common problem we face in day-to-day practice. We'll have the discussion at the end of the session.
Yes,
we'll
sir.
go to the
Thank you.
next presentation.